At our hospital, there's about 5 or 6 of us that do direct anterior hips. We're probably 98+% direct anterior approach for all of our hips. And at times the tables became a commodity that was difficult to get to. So we were limited to a certain number of days and a certain number of anterior hip rooms that could be running simultaneously. So I was looking for something that I could get off the table to eliminate my dependence on a traction table so that I could start doing these. The other thing is that, so I'm a trauma trained physician, and my good portion of my practice is trauma surgery. And so I do a lot of femoral neck fractures and hemiarthroplasty. Based on time constraints and the traction table, I was still doing all of my hemiarthroplasty procedures as a anterior lateral procedure. And I wanted to bring the benefits of the anterior approach to those patients. However, due to time constraints, I didn't have time on a busy fracture room day to perform these via direct anterior approach. I think I've actually seen probably a bigger improvement in the outcomes amongst my hemiarthroplasty patients now going to the anterior approach. We've got a good number of these patients that are now going home as well as not requiring any type of additional inpatient stay and leaving the hospital significantly quicker. So for me, one of the primary goals was to expand it into that. And then again, the same thing, the OR staff has seen it and they keep talking about it, and they've noticed the efficiency and the laid back mentality in my room as opposed to the other rooms. If you have a complication or an issue on the table, it can be quite difficult sometimes to deal with it because of the patient positioning and the limitations of that. I think with the leg draped out, if you do get a calcar crack or something along those lines, it doesn't drastically increase the surgical time because you can address it readily and quickly.